So when you had these patients that were in, respiratory difficulties, how are you handling these aerosolized procedures such as, neb treatments or intubations, BiPAP, CPAP, when you had a department full of them?
Well, honestly, our threshold for doing the treatments that we would normally do actually moved, where I would be much more prone to say, oh, you sound wheezy, your oxygen's a little low, let's throw you on this breathing treatment, or let's move you to the BiPAP, or oh my gosh, you're getting bad, let's intubate you. We had to move those thresholds because every time I went to do any of those things, I risked exposing or locking down a room. So just an asthmatic kid that's coming in who may also have COVID, normally I would just throw the breathing machine at them. They would be feeling better. They'd just sit in a chair, sometimes just in the triage area getting that. And that would absolutely be an anathema now because we're going to be throwing those particles everywhere. So those patients actually weren't getting those breathing treatments if they were stable enough not to. Then they may be miserable, not getting really the best care. But we had to take a cost-benefit analysis to decide, is that going to keep us from, am I going to spread the virus or am I going to help this one person? I was often decide, in some sort of utilitarian light that I need to not spread the virus and that guy can suffer a little bit so that I don't infect everybody else kind of thing.
Yeah, I resonate with that. I had a 23-year-old kid who had asthma that was also a tech on one of the COVID floors in one of the hospital systems out here. And it was the same sort of thing. We had him in a regular room because he looked kind of like, not great, but not, intubation, needed, but his lungs sounded awful. So then we had to wait for one of the negative pressure rooms to open, stick him in there, give him the, and that's a 45-minute ordeal is clearing those negative pressure rooms, or more, 60 minutes. And then so, we got him that hour-long continuous neb. He perked up, went back to another room. They let that flush out. They put another patient in there, and then he tanked. And we were like, well, now what do we do? Both of our negative pressure rooms are full. So I know you worked heavily in doing the in forming those intubation boxes, the acrylic ones. So now with the FDA removing the blanket EUA, are you aware of that? Yeah. About using these. We're now presented with another obstacle here on how we can care for both the patient and protect ourselves. So in comes the SCONE, and this is a negative pressure, essentially, intubation box that has a bunch more functions. So how do you foresee yourself using this?
Well, I like the fact that you could take this and line up patients and put each of them in this box or this, this covering and be able to utilize space better. And then at the same time, once I get negative testing back, I can bring them out of it if needed. There's always the possibility that, if I do need to get in and do a procedure quickly, that I'm not going to be exposing myself and the staff. It sounds like we're going to be a lot more versatile with the ability to function and get closer to the norm that we used to be at, which we're just so far from right now.
Yeah, I think that's a good point. As soon as a patient's brought back that you think might be under investigation for COVID, sometimes these hospitals take upwards of a couple hours to get that first test back, and it would be, I think, really beneficial to have
and that's
them
a silly
any room. Right?
Yeah, a person's going to come to triage, and sadly, the way the system works a lot of times is the patient doesn't even get isolated until the physician sees them, or maybe the nurse, but they've already been up at triage and they've been walking around, they've been going through everything. If they just kind of came in and went right into something right away, if their chief complaint was respiratory or fevers or myalgias, then that would make perfect sense for them to at least be in that temporarily, even if after I go and see them and talk to them and say, okay, maybe they don't need this, or it doesn't sound like it's a COVID patient. And that would just lower our overall exposure, because one of the best places to go get COVID right now is the emergency department. And
sounds like a fascinating pastime. Just let's go get it.
It's probably part of the reason that so many of our other things that we see in the ED have not shown up recently. Where all our heart attacks, where all our strokes. Well, people are afraid to come to the emergency department, and rightfully so. But we don't want them staying at home and suffering.
So do you foresee this making just kind of the simple act of giving an asthmatic nebulized treatments, much easier?
Absolutely. And less of a balancing act when it comes to logistics. And EMS is bringing us patients that they're not nebulizing in the back of their ambo like they normally would, so the patient is worse by the time they get to us. And that even gives us more concern because they get to us and they're starting to crash, and we can't even spend time trying to decide, well, can I get them into the negative pressure room? Can I do anything like that? We just have to nebulize them or go straight to an intubation or something like that, where if they'd have been nebulized on the way in, or while they were in the waiting room, they got moved into an area, got nebulized, it would dial us back. We wouldn't actually be chasing our tails kind of thing. By the time we actually get to the patient, and they're already in over respiratory distress.
Yeah, I think stress levels would be down quite a bit.
Significantly.
Has this affected your use of CPAP and BiPAP as well?
Yeah, I know at first we were all kind of terrified to use it. A lot of the guidelines were only do it when absolutely necessary. Then they were getting some small filters for them, and we got excited about that, and then we found out those filters really aren't the best thing, and so back and forth. A lot of these patients were just on oxygen, and okay, ride it out,
Yeah, I did a lot of high flow oxygen on patients that probably shouldn't have only been on that, sitting in the low 80s.
Yeah, exactly. But when we don't know, we don't know.